Good morning, I'm Karina Findlay, Retina Vitreous Associates partner, Steve's for 25 years, I think.
My wife and I were talking about that, like, how old is Karina? Like, I'm not sure, she always seems the same age.
The goal is not to age.
Yeah, not the age, which is easy on your pictures on the internet, your practice pictures.
Oh, which reminds me.
Yeah.
Well, I looked up one of your articles and it was a picture of you at the end. I was like, wow.
I can do all
Yeah.
these. There we go. Oh, here we go.
So, anyway, we're gonna talk about peripheral retinal lesions, some predisposing to retinal detachment, some not, as well as types of retinal detachment. This is all out of your book. I think it's chapter 16. So we're going to talk about PVD, lesions that don't predispose to retinal detachment, lesions that do, retinal tears, other lesions that cause subretinal fluid, types and treatments of retinal detachment, and then macular lesions predisposing to retinal detachment. Like,
Oh, that,
get rid of that.
hold on. No, oh shoot, I want to do that.
Oh, boy.
Drag it open. I think if you click it from the green part, wait, no, click it from the green part, it'll drag it.
Like Zoom after all these years still.
Yeah, still has some
can't find out. This
glitches.
is like a number here, like.
All right, volume meeting controls.
Okay.
Okay, and then you do slideshow. And then I gotta duplicate it. I have another computer.
Okay, there we go.
That's better. Yeah.
Probably
okay.
more like 2%.
That's good. That's fine.
There we
Okay. So posterior vitreous detachment, probably the most common thing you'll see in a retinal clinic. Patients come all the time with floaters and flashes. The vitreous is firmly adherent to the vitreous base. Vitreous base, optic nerve, macula, and retinal vessels. Age-related vitreous syneresis, liquefaction, and detachment will cause traction on these firm areas and occasionally a retinal tear. Common symptoms, floaters, flashes, blurred vision. I'm sorry. Oh, okay. Common symptoms, like I said, floaters, flashes. In your book, it says about 7 to 18% of patients will have a tear. It's probably less than that, probably about 2%. The common location for retinal tears are at the posterior edge of the vitreous base, because that's where the most traction occurs. And then when you're doing your exam, when you see vitreous pigment, you really have to look for a break because there's likely one there. So can you just?
Yeah, you can do that. Do it.
No. So hemorrhagic PVD is when when vitreous occurs at a retinal blood vessel, or you can have a blood vessel bridging over a tear that can cause a hemorrhage. About 50% of patients will have a tear when there's a vitreous hemorrhage present. So when you see these patients, you really want to follow them closely. Sometimes the vitreous hemorrhage is so thick that you're not able to see the periphery very well. So you want to do a B scan to further rule out retinal detachment. And then, like I said, close follow-up is recommended due to possibility of retinal breaks or delayed retinal breaks. So this is a picture. It's supposed to show a white string. This pointer's not. Oh, no.
Yeah, the pointer's not very
Right
good.
there. Right there. So when you see these patients, you want to do a slit lamp exam, mainly to assess for vitreous pigment in the anterior vitreous and to detect a white ring. You don't always see a white ring, but if you do see it, then you know it's pretty much a complete detachment. And then probably the more important part is indirect ophthalmoscopy with slow depression to evaluate for retinal tears and retinal detachment. The OCT is helpful because you can actually see the macular cross section, and you can see where the vitreous face is, and you can see different stages of vitreous detachment. And I know you like to grade those. Yeah, you talked about it.
I think
I started to do that, and I'm like, oh no, this is too much.
I thought about it too.
It's too much. So some of my-
PVD or no PVD.
like
partial
grade
PVD.
3, grade 2. It is important in the sense that if you have a patient with vitreomacular adhesion and they start to pull up on the macula, you do watch those, but otherwise, yeah.
The RNFL is probably even more helpful than the OCT
Yes.
macula to tell if
there's
their
a complete
PVD
PVD.
status, if you need to know.
Yeah. And then, so again, B-scan, if you really can't see the periphery very well, and they say that's the gold standard for detecting a PVD. I don't usually do it routinely for that. And then follow-up can be anywhere between 2 and 4 weeks, depending on risk factors. Again, if you see a vitreous hemorrhage, I tend to follow them pretty closely, upwards to weekly sometimes. So risk factors, if they have lattice, if they've had a retinal tear or detachment in the fellow eye, if they're highly myopic. Also, if there's a family history of retinal detachment, I kind of follow them maybe slightly more closely. The IRIS registry reviewed over 400,000 eyes and showed that a delayed retinal tear can occur in 2.42 patients at approximately 6 weeks. So I do continue to follow PVDs. I'll see them initially, and then if they're pretty uncomplicated, I'll see them like a month later, and then I'll see them one more time just to make sure. But all the time, you have to warn them if you have any increased floaters, flashes, or especially shadow to call and come in. And then I always warn patients that this likely will happen in the fellow eye at some point, and you have to tell them you can't predict, it's spontaneous, and just to call if they do have symptoms. And patients are pretty good about that.
Karina, how often do you get a B scan?
I only get a B scan if there's a vitreous hemorrhage.
You get one though. Oh, it's only vitreous hemorrhage, okay. If you
Yeah,
have
I
it, if the
don't do
patient's
one.
squirrely,
I don't, because I'll do an RNFL OCT, and that will
No,
tell
but
me if there's a
per tear.
vitreous, per tear.
Just make them sit there.
I just make them sit there. I make
yeah,
them
have you done a B scan?
No,
I've never done.
No,
Okay.
I just make them sit there.
better on my exam.
Yeah,
with
than a
B-scan
B-scan.
for
Okay.
detecting tears.
Yeah.
I felt because you saw a patient I had seen with a detachment. Every time a patient comes in with a detachment after I've seen her BVD, I'm like, oh, I wonder if I missed the tear. And I wonder if I should have done a B scan, but I've never, okay, so you've never done,
I
you've never done
don't,
it.
no.
Okay, other than vitreous
No,
hemorrhage,
because I feel like my
My exam
exams,
was 3
yeah.
days after,
yeah.
so it's like,
if I feel like I can't get a good slow depressed exam, I'll do like a 3 mirror. I'll do like a lens exam, and that's
But not a
usually,
B-scan.
I'll just
I
bring
don't
them,
do
I
it.
just bring them back. I'll just say like, okay, well,
yeah.
you have to come back.
You
next
earned
week.
yourself more visits.
Yeah, exactly.
You would just behave.
If you would just sit there, you wouldn't have to come to work next week, but.
Okay.
So lesions that do not predispose to retinal detachment. So basically, the difference is vitreoretinal traction versus no vitreoretinal traction. So these lesions do not have vitreoretinal traction. I put a question mark next to meridianal folds because there's like,
The textbook has
There's
it now. They've
conflicting-
switched it. Yeah, that's switched, which I
So
don't think
I
is
don't know.
correct.
anyway.
Because they tend to be in the vitreous space, so you shouldn't be able to get a tear from them.
Yeah, okay, well, talk about it. So paving stone degeneration, you see this very commonly in patients. Usually as patients get older, it's more common. It's due to ischemic changes. You'll see focal areas of retinal and choroidal atrophy, very distinct hypopigmented areas, pretty far in the periphery. Sometimes you have to slow press to see them, usually in the inferior quadrants, and increases with age. And there's a little picture of that. Sorry, I was trying to get one of my own patients, a picture, I just couldn't get one.
Oh, it's a nice
There,
picture.
yeah, well, that was from the book. All right, and then other lesions that you see very commonly as well, retinal pigment epithelial hypertrophy. They're just like little pigmented areas. You can see like a chirpy, and sometimes they'll have central lacuna. Sometimes you'll see bear tracks. It's a whole nother lecture. Probably the most common thing And I feel like it's probably more common in macular degeneration patients. You'll see like this reticular pigmentary pattern in the periphery, and that's very common. And that's just, and it's an old finding. I don't even really mention it. Mostly it's just something you see commonly.
A lot of this stuff is nice if you have to put something in the chart for a visit.
Yeah, I
You're like,
guess if
because
you
you
have to put
the
a
patient comes in, you have to
diagnosis,
put a
then you have
diagnosis.
to, yeah, that's
Okay,
true.
that's something all of you guys will learn
Where are you?
when you're in practice, that, you know, your chart can't just be blank,
Yeah.
or you can't bill for the
You
visit,
have
right?
to,
So you have to
yeah, you have to find
You have to
something.
Disturbance.
put something,
Hypertensive.
Yeah,
Retinopathy is a perfect
cobblestones
one.
you know, something.
Peripheral,
without
this one's
pressure.
typical, because 85%
Yeah,
people have.
yeah, so
I used to
this
use
is-
that one. Typical peripheral cystoid degeneration.
Yeah, yeah.
Evidently, is it true if you feel hypertensive retinopathy, you have to check their blood pressure in clinic?
I do commonly
You
anyway.
do? Okay.
But I
Um,
don't think that, I don't know that.
I don't think so. I
I don't know
don't,
if
it
that's
is
true,
kind
yeah.
of one of those parameters that they kind of want you to check
Gotcha.
this whole government
Maybe the
mandate
first
thing.
visit.
But I usually do.
Okay.
See that.
Just
Yeah.
curious, 'cause that's what
Yeah.
we're told in our retina clinic, that you have to check blood pressure.
That might be true.
It's not a bad idea to check.
Yeah, you should, it actually is really
Do
a
that.
good thing. I had a patient, going off topic, who came in with bilateral optic nerve edema. And I'm like, and there's no blood pressure on the chart. I'm like, what's the blood pressure? And the tech's like, well, we can't get it. And I'm like, yep. Better check it. Sure enough, he went to the hospital, but anyway. So this is also very common, typical peripheral cystoid degeneration. It's bilateral. You'll see it kind of looks like a little, like, kind of just a bunch of little cysts. And it's located in the outer plexiform layer, so a little bit deeper. And then it can progress to typical retinoschisis if these little cysts coalesce. And then reticular peripheral cystoid degeneration is more posterior. And the cysts are located in the nerve fiber layer, so a little bit more superficial, less common. And then that can predispose to bullous retinoschisis. And then white and dark without pressure, you see this very commonly as well. And sometimes you'll get like a referral from an optometrist thinking that there's a retinal detachment. And sometimes it can look like that, but the best way to rule that out is slow depression, because you'll see that the vessels are not raised and you can see that it's all flat. Does not have any impact on vision. It tends to happen in very dark pigmented eyes. I actually have it, I'm told, so I don't know. They used to think it was due to the vitreoretinal interface, but they also found that you can see hyperreflectivity at the epsilon zone on OCT. And then dark without pressure would have hyporeflectivity. So I guess it is a finding you can see on OCT. I've never looked for it. And then meridional folds, enclosed orbits, peripheral retinal excavations. So meridional folds are just redundant retina, and usually see it in the superior supranasal quadrant. I've never seen a tear specifically associated with it, but it can sometimes look like a tear. So you just kind of want to just make note of it. And then aura bays are just islands of pars plana posterior, which is surrounded by retina, which I guess technically I've read it can have some vitreoretinal traction, so can predispose to tear. And then peripheral retinal excavations, which also is said to have some vitreoretinal adhesions similar to lattice. So given that, I guess it could predispose to retinal tears. If you see these, you just make note of them.
And the enclosed aura bays look exactly like tears.
Yeah.
That's one of the hard things. So you depress, you see retina with this thing in the middle.
Yeah.
And then you gotta realize you're like way far out. It takes a long time to get, I mean, indirect ophthalmoscopy took me a long time. to
Yeah,
get
I mean, the
that.
slow depression is so important because you really look for like that little flap of
Right.
tissue, which, you know, tells you if it's a tear. And then this is a picture of a meridional fold. They kind of look like tears, and they're very far out in periphery. And then aura bays, these are a couple pictures. And they can look like tears when you're doing your exam. And then retinal tufts, there's 3 different types. So one type is not necessarily associated with retinal breaks. That's the non-cystic tuft. And they're just projections of retinal tissue. And some are associated with vitreous or even zonular traction, and they're seen within the vitreous base. Non-cystic tufts are common, seen in 72% of eyes, non-associated retinal tears. Now, lesions that are predisposed to retinal detachment, so cystic retinal tufts, lattice degeneration, retinoschisis, and then retinal tears, of course. So again, the vitreous is very adherent to the vitreous base, the optic nerve, blood vessels, and macula, as well as lattice. So these are potential areas of problems. Vitreoretinal tufts, like I mentioned, are just focal areas of glial tissue with vitreoretinal attachment and can predispose to tears. You see these pretty commonly. I just make note of them. I don't treat them. But if a patient has an acute PVD, you just want to look at those areas when you see them, just because they can be sites of tears. A lot of times they become operculated tears because the vitreous just will pull the whole piece of retina off. And you'll sometimes see pigmentation around them. Here's a picture of one. You see about 5% clinically. I think I see them a little bit more than that, maybe. But low risk of retinal detachment, 0.1%. So you don't necessarily treat these, you just make note of them. There's another one, which could predispose to a tear.
Yeah, sometimes when you see a tear, you see that little thing on the tip of it.
So
That's a tuft.
that's the tear there. That's another one, the tear. If you have questions, just stop me. So this is another, I think it's a frozen section, and you can actually see the tuft with actual vitreous traction. I think that's a very cool picture. You can kind of frame it. So then lattice degeneration, which is, see it pretty commonly, I'd say about 8 to 10% of patients will have this. And you'll see it's kind of an incidental finding. Patients usually don't have symptoms from this unless they have an acute PVD. And it's basically thinning of the inner retina. And the important thing about this is that the vitreous tends to be very adherent to areas of lattice. So they can be sites of tears. They're bilateral up to 50%, more common in patients who are myopic. And they can be pigmented and non-pigmented, and they may have atrophic holes associated with them. So this is one of my patients. So that's kind of a non-pigmented one and another pigmented one.
This is like one of the most common referrals to our retina clinic from optometrists for people who have no symptoms. I would say.
Yeah,
With lattice, especially with atrophic holes.
yeah.
You guys treat lattice typically at the VA, or do you watch it?
Only if there's a tear.
What about the second eye? If a patient has a tear in one eye and they have lattice in the other eye, do you treat it or watch it?
We talk about that in a minute.
That's my comment. It's like
It's coming up.
it's like a pretest question. Yeah, so yes or no?
Yeah.
Yes, typically you do.
Yeah, I tend to. So basically it's retinal atrophy with firm vitreous attachment. Usually you'll see it parallel to the aura. Sometimes you'll see radial lattice associated with blood vessels. And those, if they develop tears, are a bit more posterior. So it's called lattice because you'll see these white blood vessels and they look like a lattice pattern. And sometimes they can be quite subtle. And so you want to, again, do a good sclerodepressed exam. Are you guys allowed to do those in clinic? Back when I was a resident, Paven would never let us sclerodepress ever because he didn't want his patients to complain, I guess. And so the only time I sclerodepressed was at the VA. And so I never really got good at it until I got out of residency and then did it.
That's so funny. Just practice.
He would never let us sclerodepress. Don't sclerodepress.
I would like to interrupt to say that I deny that. I'm sorry I'm not there. I have a cold and you all don't need it. It's I don't remember that, but I'm old and it might be just my senility. But it sounds like something I would have said to someone, yes.
Never let us go to press. That's hilarious, I didn't realize.
Nice to see you. I was gonna say,
Amazing what trainees remember. It's like children.
I remember
oh, little.
And the other thing I remember,
Yeah.
Dr. Paven, is we had, our notes were on these like multiple copies, and so they're all carbon copies, and we had to write. And he would get so mad if he didn't write hard enough that yelled at him for it. And I'm like, I can't help it, this is the way I write. I remember that and the slow depressant. Anyway. But I will say, you've done a slow depressed exam on me, and you are very good at it, Dr. Paven. I hardly felt it. It was great. Anyway.
The key to scleral depression is to use a small scleral depressor and go lightly, because if you use a broad depressor, you don't see the indentation easily. Because you can't compress, because you're compressing too much. And you're trying to compress water, that doesn't compress. So
do you always use the small end? There's like two ends. Do you always use the small end?
I used a scleral depressor. I don't know where I picked it up. It might have been from Watsky, but it's got a pretty narrow end. And so with that, you don't have to press hard, and you can get nice depression. And that's go ahead.
No, I was just gonna say, I remember you always saying that you don't try to actually press on the globe, that you just kind of slide it, just kind of posterior. And then you don't have to really press to actually see the indentation. And that does make it very comfortable.
I use the NICU one that we use for like baby exams. I just take it and then use it for guidance.
Okay.
Nice.
The one with the little spoon on it?
No, I wish, because I love that one that they have at all
Yeah.
children, the Dr. Has uses.
Yeah.
It's so easy to see.
So which one do you use here?
No,
for
it's like the
kids?
little blue one that comes in the NICU.
Oh, okay,
Oh,
yeah, that one.
It's just so
Yeah.
tiny, so.
Yeah.
Okay. We're all learning something here. Anything else, Dr. Paven?
Not at the moment.
Okay. So lattice degeneration, so, in 20 to 30% patients that have a retinal detachment, you'll see this. A retinal detachment occurs in about 1% of untreated lattice. So typically you don't treat lattice unless there's a high risk situation. But they did a study looking at almost 500 patients, and patients who've had a retinal detachment in the fellow eye, you can really decrease the risk of a retinal detachment by 17% versus 41%. So I have always, when somebody has a retinal detachment, I've always treated the lattice in the other eye. Probably the few times I haven't, they've come back with tears in that area, and you're just like, ugh. And you tell the patients that it doesn't prevent a tear or a detachment. All it does, really, the laser, is to kind of barricade the area. So if and when they do develop a tear, at least it keeps it a safer situation until they can get to you, and you can then either add laser or do something. It tends to decrease that progression, but you always have to warn them that there is a risk. It's still going to happen, even though we're treating you. It just helps keep it a little bit more isolated. And then you'll see atrophic holes within areas of lattice, and sometimes they can lead to retinal detachment, usually in younger patients. And these are usually kind of like these kind of slow chronic retinal detachments that could occur, and they're not really symptomatic until it gets into the macula. I just had a 22-year-old college student with that very situation. So anyway. So you do watch these atrophic holes. You don't have to treat them, but I tend to watch them. So this is a picture of lattice, and then you can see there's an atrophic hole there.
How often do you see those patients, asymptomatic patients with atrophic holes?
All the time.
No,
Oh,
how often do you bring them back?
Oh, how often? Like yearly.
Yearly.
I don't know if I ever bring it back.
Don't bring them
I
back.
kind of
I
think
do.
I'm all right.
I often see them yearly.
Yeah.
If they have a really good optometrist or general
Right,
ophthalmologist,
then
I
I
let
let
them
them
follow it.
them, but
But
if they
otherwise I'll see them
don't,
yearly.
You bring them back, Steve?
No.
I typically tell them, look out for flashes and floaters, and you know where to find me.
Because if they get an asymptomatic detachment, I won't actually necessarily.
No, you don't, but you watch them closer, but sometimes they extend
Right.
and then.
But the risk of a
Yeah.
detachment from an atrophic
Oh,
hole in the
It's
lead is
pretty low, yeah.
Yeah, I got injections to do.
I know, you guys are, I know, you're planning to see these
You gotta
patients.
teach
it's fine.
others, you gotta be over here. Gotta be over here teaching your residents. One important thing.
Retinoschisis, occurs in about 7 to 8% of patients. You'll typically see it infratemporal, typically bilateral, and that's actually a good way to, one of the ways I kind of tell if it's schisis versus a retinal detachment is if it's bilateral, it likely is retinoschisis. And then there's two types, typical and reticular. So typical retinoschisis tends to be more flat. The retina splits in the outer plexiform layer. You'll see sometimes these white dots or snowflakes, and those are foot plates of the Mueller cells. You'll see sometimes sclerotic retinal vessels. They tend to be more isolated. They don't tend to progress and rarely cause retinal detachment. And then reticular is the more bullous form of retinal detachment and retinoschisis. And sometimes they can kind of look like chronic retinal detachments. One of the ways I've been told that retinoschisis tends to be more common in hyperopes. I don't think I've ever read that. I think I've just been told that. But when they're myopic, you can kind of think, okay, maybe more retinal detachment than retinoschisis, but I don't know if that's really.
I just got that question wrong by not knowing that, like a
Oh,
BCSE question.
Oh, so it is a thing.
Oh,
Yeah,
okay, it
they
is
say
a thing, because I
hyperopes
remember
is
Scott
actually
told me that
retinoschisis.
years
Okay, I never
ago.
read
Can you
it.
say that one more time?
So retinoschisis tends to be more common in hyperopes.
In the book, I just got it wrong.
Really?
Put it in
Okay,
that.
all right, well,
Yeah.
there we go.
Yeah.
Posterior extension can be more common. The inner layer is very thin. Probably because the retina split in the nerve fiber layer. And then you'll see these outer layer retinal holes, and these may progress to retinal detachment. And there's a picture. It kind of looks like an RD. These are pictures of outer layer retinal holes. So basically when I'm looking at a patient with this, I'll look for these bridging blood vessels. You can really see that the hole is like behind. So again, slow depression is very useful in detecting these two. So these are associated with 3% of retinal detachments. You'll see this slow progressive type, which is kind of what is here. This is one of my patients. This is not laser for that. He had a BRBO with new vessels. So that's PRP because of his BRBO. I don't treat these. I just watch them. I looked at that. I'm like, oh, the picture has laser. They probably think I lasered that. That's something else. But anyway.
That's a nice photo.
Yeah.
Lots of stuff.
Yeah. So, so the slow progressive type, you'll see pigment. And so when you see lattice, and if you see some pigment associated with it, you can pretty much say that it probably is associated with a retinal detachment. I don't tend to really follow them any closer than I would otherwise with these types of findings. And they don't require treatment. So then there's a rapid progressive type where you have holes in the inner and outer layer. And so then the schisis cavity can collapse and you can get fluid behind the retina and it can detach, and they can be kind of difficult to treat sometimes. Typically you do a vitrectomy if there's posterior holes and you want to try to just flatten the whole schisis cavity and retinal detachment, laser it, and yeah, they're not always fun, but.
And the outer holes can be very hard to see.
Mhm.
And to fix it, you gotta get those.
No,
So,
it's the inner holes. It's the inner holes. You can't see you never see the inner holes.
I've seen the
Yeah,
inner holes,
yeah.
to me, sometimes they look like tears.
Really? Well, maybe we're talking about,
Sometimes they're just
They're smaller,
fenestrated,
right?
yeah,
Smaller
sometimes
than the
it's
outer.
just like cheesecloth, but sometimes
Yeah.
they're.
yeah, I've never actually seen an inner layer hole to my knowledge. I always see the outer layer holes, and if business was slow, I'd laser them. But they usually don't need it. they're large holes, and that's one of the giveaways. They'll like be 2 to 3 disc diameters at least. And
Funny.
they don't do anything. They just sit there forever.
Yeah.
So,
Ways you can tell a retinoschisis versus retinal detachment. Some of these I've never done or do, but anyway, theoretically, retinoschisis will cause an absolute scotoma, probably because it's like split within the retina, versus a relative scotoma with retinal detachment. I've never checked for that. Schaefer sign, which is the pigment in the vitreous, is more common in retinal detachment. Retinoschisis areas look smooth and dome shaped, but again, you can sometimes be fooled if there's a chronic retinal detachment, it can look very much like that. Acute retinal detachments have more of a corrugated surface. If you see a pigment demarcation line, you can pretty much say that there's probably some subretinal fluid there. You can laser retinoschisis, and the retinoschisis will take up the laser. I may have done that once 20 years ago. I don't really do that. But now that we have OCT, it's really a good way of determining. So I try to get my techs to get a peripheral OCT, and this is kind of the difference. So the top picture is retinoschisis, and you can see how it's split within the retina versus a retinal detachment where the whole retina is separated, and you'll see the subretinal fluid. So to me, that's like a really good way if you can actually get a good picture out there to determine the difference. So retinal tears, obviously can predispose to retinal detachment. You have horseshoe-shaped tears, which are the higher risk tears. And this is because the piece of the retina is pulled anteriorly and there's persistent traction by the vitreous at the edge of the tear. So the tear can be lifted up, fluid can get behind the retina and create a detachment. Or percolated holes, and it's funny when you describe this to patients, you tell them, well, you have a retinal tear, but you have a tear where the vitreous actually pulled a piece of the retina off, and they get this look of horror on their face. I'm like, no, but that's a good thing because then the tear is flat and fluid is less apt to migrate behind the retina and create a detachment. So percolated holes, you can usually watch them. And then you have giant tears, which is at least 3 clock hours along the posterior edge of the vitreous base, as opposed to a retinal dialysis, which is a complete disinsertion of the retina. And retinal dialysis is associated usually with trauma. And then atrophic holes, we talked about seeing with lattice, not associated with vitreoretinal traction, but uncommonly can predispose to detachment. And this kind of shows you a flat tear where you have persistent traction by the vitreous, and potentially fluid can dissect underneath that area and create a detachment, as opposed to a complete piece of the retina coming off, and then this area tends to be flat, so less apt to develop a detachment. And then asymptomatic breaks, you'll see these pretty commonly. A lot of times they'll have pigment around them. So you just kind of tell the patient, you know, you've developed a tear at some point. Usually they're asymptomatic. You can see horseshoe-shaped tears or atrophic holes with pigment. Very low percentage of retinal detachment, either subclinical or clinical. So I usually just watch these. Like I said, yeah, asymptomatic tears, less risk of becoming a problem. There are higher risk situations in patients with myopia, lattice, pseudophakia. If they have a retinal detachment in the fellow eye, you might, treat them differently. And it also depends on the location. So sometimes when they're superior, if they have a retinal detachment in the fellow eye, it just depends. Sometimes if they're about to have cataract surgery, I'll treat them just to protect that area before they have their surgery. And then, like I said, operculated holes and atrophic holes are incidental. This is a operculated hole, so you can see a little piece of retina there, and the hole is flat. Sometimes I'll treat operculated holes if they're associated with an acute PVD and they have hemorrhage around them. And I actually had one the other day and I was like, well, I guess I'll laser it. And then when I lasered, I actually saw, because when you get the contact lens on it, you can really see the details, and it did have a flap there too. So I was like, oh, good thing I'm treating it.
What would you do with this whole, if this patient comes in and says, I've had flashes for 6 months, no floaters?
I probably would watch it for 6 months.
I feel like I get this a lot. They
Yeah.
come in, they're like, I have flashes, and then I see a little hole.
And it also depends on the patient. If you're like
Patient will
super
call you.
nervous.
Yeah.
I had this young patient, like she was in her early 20s and she had a percolated hole. I don't remember now, but anyway, she was so nervous. She's like, I'm starting PA school. Am I gonna go blind? I'm like, no, you're not gonna go blind. But she was just, I'm like, you know what? Let's just treat you.
Except the treatment's pretty benign.
Yeah,
It's so
treatment's super
benign. It's so benign. You tell them it's not gonna affect your vision. It's just a small area in the periphery.
I tend to lean towards treatment if there are any symptoms. If they're completely asymptomatic, I tend to lean away from treatment.
Yeah, I don't know,
For-
6
for-
months. It really depends on their course. If the flashes are increasing, if there's floaters. There's no cookie cutter way to treat retina issues. So symptomatic tears are kind of in a different category. They have a higher risk of progression to retinal detachment. Probably about 2% of patients with an acute PVD will have a tear. And that's kind of important to tell patients because they come in with these symptoms and they're sure they have a tear, and they look it up on the internet and they're like, I have a tear, I have a detachment. And you have to kind of tell them, well, no, you don't. You have a vitreous detachment, and they always confuse vitreous with retina. And then you say, well, really tears occur in a very small percentage of cases, and typically you're going to be fine and no issues. So you kind of have to really tell them how low the risk is. If you see a vitreous hemorrhage, of course, there's a higher risk with that. So you do want to monitor them closely. You also ask them about blood thinners, because sometimes if they're on blood thinners, they will have a vitreous hemorrhage, but not necessarily a tear, but I still watch them regardless. And then treatment is recommended for acute tears. That's pretty much not really controversial. And then treatment for percolated holes, if there's traction, if they're larger, superior in location, or higher risk just because of fluid and gravity. And then vitreous hemorrhage, if they have any hemorrhage associated with it, I tend to treat them.
How long does it usually take for like, if there's a superior flat, like acute flap tear, but their vision's totally fine, it's not anywhere near the macula? Say if they like come in on like a Saturday morning CGH, but there's like so many other people, maybe it's PGY2 who isn't like super comfortable lasering tears, is it fine to wait till Monday in a clinic setting? Okay.
I think so. I tell
I've always
patients.
wondered like, how acute is this that you need it?
And
like,
it
right
also
now?
depends too. I mean, if you start to see fluid, I mean, if it's just a flat tear
Right.
and no fluid or
20/20.
anything, I would just say, just sit tight, don't do anything crazy over the weekend
Right.
and come in.
Go find a
first thing on
constellation for
Monday.
you to like bring somewhere. Okay.
Pertaining to that, it's been shown that if you do cryotherapy, it takes 2 weeks before you get any adhesion at all. And
That's true.
with laser, I believe you get some adhesion, but in the literature, it used to say that you don't get an adhesion with laser until about a week out. So you've got to tell a patient to be
They're already
quiet.
sitting adhesion for a few days, and usually they're
Yeah.
fine. So that's a good point, yeah.
Some of it has to do with patient and referral management. If we get a call from an optometrist
for
on
us,
Saturday
Yeah,
and there's a tear superiorly, the answer is not come in Monday. The answer is come in, you're concerned about this patient's safety, you're concerned about this patient's prognosis, we're happy to laser them on Saturday.
There is a kickback on that,
What's
which
that?
I don't know if it works anymore. But I remember Frank Seidel called me when I was probably 35 and starting practice with a retinal tear. And I said, okay, I'll see you right away. And he said, can you see it tomorrow? I was like, I guess, yeah, because it's Medicare billing.
Oh, yes.
Because sometimes it's two ophthalmologists bill in the same 24-hour
So
period.
few optometrists bill medical insurance anymore. It's probably less of an issue than it used to
But if
be.
you just want to use it,
Yeah.
you want to say,
Yeah, I mean, again,
I can
that,
see him today, but with, might
But
screw up your.
it might screw up your
reimbursement.
billing.
Yeah, and you got that.
I never thought about that. I mean,
That-
yeah,
that's really
typically,
interesting, though.
You're looking for something. that-
yeah,
you're at, like,
typically if
baseball.
the referring doctor calls you, you want to take care of it
Mhm.
because it's your referral.
Yeah,
And that's
Yeah,
good
outside of,
business
like, the-
practice, but in your situation, like purely medically,
yeah.
it probably could.
I tell those second year resident, no pain, no gain. That's
Yeah,
what we-
yeah.
That's what they would tell me,
Yeah.
first year resident, you sit there until it's done, don't come out of the room.
That's true.
And that's the only way I learned. It was horrible, but by the end of that year, you can laser anything. If you're not allowed to exit the room until it's done.
They laugh.
That's part of it too. The reason there are people who are not comfortable with procedures is because they haven't done the procedure enough.
Yeah.
Yeah, honestly, in
Curious.
residency, you
Yeah.
just have to do as much as you can, so you're comfortable when you leave. I mean, really, it's,
There are fewer and fewer people to ask for help in the moment,
Yeah.
right?
yeah,
So, try to get everything done you can while there's like a team of people to help you.
Yeah, I think it's that, it's like wanting to do it, but like when you actually have it, rather than like by yourself in the
Mhm.
hospital, but like in clinic, like doing.
It's a
the
perfect
things you
time.
can
Nobody's
do.
watching you. The patient
It's
doesn't
true.
know. Numb them up. Hang out for an hour.
Take 2 hours and.
Yeah. Perfect. You got the laser, right? Is there a laser here?
Mhm.
Is there an indirect laser here?
Mhm.
So
No,
you got a Q-tip.
You gotta
and
just sit in the
indirect
room
laser?
there, you're not gonna, it's the only way you learn how to do
It's
it.
not gonna teach itself.
Yeah.
Yeah.
People do pass out during laser sometimes.
Well, if they're
That's
laying
laser.
back then.
I was lasering a guy this week, who he passed out twice during, like, I'm gonna pass out, I'm like, okay, flip him back, go see another patient.
No, maybe that's the perfect time to finish the laser.
Yeah. They're nice
And
and
also, if
quiet.
you're doing these, I do subconjunctival anesthesia on almost 100% of my peripheral lasers.
Oh,
now.
do you really?
And I find that
Oh,
it's
wow.
much.
I don't do that.
Much quicker and
Okay.
easier,
Huh, okay.
because they really
I do
do,
that for cryo, but I don't do that.
they
for
whine
laser.
and complain. I think it hurts,
Oh.
No pain.
I tell him it feels like a tattoo.
I always tell them it
Feels like a
doesn't
tattoo.
hurt.
And then you find that one person in Pinellas County doesn't have a tattoo, it's like, I don't have a tattoo, it's like, no way. You live in Florida. Back to New York.
I think you whine, you too. It's true, sometimes when they have tattoos and they're whining, I'm like, come on, look, have you seen your arm? Have you looked at your arm? This is not as difficult or painful as all this stuff on your
One
arm.
of my patients told me that feels like a tattoo, I'm like, I like that.
Don't have tattoos. Anyway, what you want to do with treatment is to create that chororetinal adhesion that prevents fluid from tracking behind the tear behind the retina. Either laser or cryopexy. I love cryopexy. To me, it's so much faster than any laser, so I try to do it.
Cryo's really good, I've heard people say that.
I mean, the patient doesn't love it because they visibly see, because I do a subconj anesthesia with that, and so they can visibly see their eye red, whatever, but it's so fast for me, I'd rather just do that than deal with the laser. But anyway, I did laser this patient. You can see that. That's the flap there, and that's the laser. So factors to consider: symptoms, size and location of the tear, so superior versus inferior, inferior being less risk. Presence or absence of vitreoretinal traction, flap tear versus a percolated tear, subretinal fluid, and sometimes you'll see them on the indirect exam and not appreciate how much subretinal fluid there is until you start lasering, and you're like, oh, okay, you have to keep going out further and further, and you're like, okay, guess what? Good thing I'm treating them now. And then also, fellow eye status, if they've had a detachment in the fellow eye, family history of retinal detachment, I do make note of that. And then you have to tell patients that just because we're treating, number one, it does not get rid of your floaters and flashes. You got to warn them about that because they think that you're curing everything by doing the laser. And then you also have to tell them that this does not decrease the risk of another tear occurring. And once they've had a tear, there's a risk of having another tear. So you have to always warn them of the symptoms, and I'll see them back in 1 to 2 weeks anyway to check, but you always have to let them know that your symptoms could worsen. And then this is from your book. So basically, if they're symptomatic and acute, you're going to treat. Basically, if they're asymptomatic, it depends on the situation, whether or not you would treat. So retinal detachment, there's three types: regmatogenous, tractional, and exudative. Regmatogenous is caused by a retinal break, causing fluid to pass between the retina and the RPE. Tractional is due to pre-retinal membranes actually pulling up on the retina, not necessarily associated with a break, although it can be, and then you have a combined regmatogenous and tractional detachment. And then exudative is caused by an actual lesion or leakage, which causes an accumulation of subretinal fluid behind the retina. And it's important to make all these distinctions because they're treated completely differently. So regmatogenous retinal detachment is probably the most common thing you'll see. When you see a detachment, you really have to look for a break because there's going to be a break there. And then there's these link off rules that you can kind of keep in the back of your mind for the most likely location of a break. Although even if you find the primary break, there could be breaks elsewhere, so you still have to look everywhere. And it is important for planning for surgeries. So when you have like a supratemporal or supranasal, typically the tear will be in the highest part. If you have a complete superior, it's usually around 12 or 1 or 11. Inferior detachments, again, the higher area of the detachment likely will have a break, although you can have breaks inferiorly. And then if you have a bullous detachment, sometimes you'll have a break superiorly. So like when you get a referral and they're like, well, they have an inferior detachment, you're just like, okay, so I got to plan surgery, whatever. But sometimes you'll see a superior break and you're like, we can do a pneumatic on you. So, so you really have to look around. You might have a little bit of guttering of fluid, and then you'll see most of the detachment inferiorly, but the actual break is up above. But it is important to really look at that inferior retina because that will make or break your procedure. Because if you have a patient with a superior break and you're like, oh, you can do a pneumatic, if they have a break down below, the pneumatic's not going to work. You're not going to be able to do it. So you really have to look at every area, and that's really important to plan for the right surgery. So this is picture of a retinal detachment, symptoms of floaters and flashes. The intraocular pressure can be high or low. You'll see pigmented cells in the anterior vitreous, and I do look for this because if you see pigment, there's going to be a tear, and so you really want to look and find that tear. As opposed to retinoschisis, this has more of a corrugated surface. This is your typical acute retinal detachment with a horseshoe-shaped tear. And then chronic detachments will look thinner. You'll see sometimes these macrocysts in the detachment. Acute detachments will actually kind of move around with eye movement as opposed to like retinoschisis, but you don't typically will see shifting fluid with a regmatogenous detachment. So risk factors, pseudophakia, you don't see many aphakic patients, mainly pseudophakia. So you can get with cataract surgery anterior shifting of the vitreous, which can predispose to a tear. Even the risk can be increased up to a year. Usually patients who are pretty nearsighted, you do want to watch them. Sometimes the cataract surgeon will send them if they're highly myopic and you'll see them before. And sometimes I'll tell them to come in after or just have their doctor just make sure they do a peripheral exam. Fellow eyes, retinal detachment patients. I tell patients once you have a retinal detachment, there's a risk of having it in the other eye. They don't like to hear that, but you have to tell them. And once patients have had a detachment, they're very good at picking up any symptoms, especially if they've come in with a macular off detachment. Well, if they have symptoms in the other eye, once they see that shadow, they know what it is and they come in pretty quickly. So it's a good thing. And then there's a lower threshold for prophylactic treatment. So if they have lattice in the fellow eye, I do tend to treat them for that. And then if they have a subclinical retinal detachment, which is like 1 to 2 disc diameters of fluid around a break in the periphery, they can sometimes progress. I don't necessarily treat them, but watch them depending on symptoms. If they have a pigment demarcation line, there's a lower risk. And then risk factors, high myopia, family history, vitreous detachment, any type of trauma, high risk lesions like lattice. And then if there's a patient with sticklers or Marfan's, they are at a higher risk also for retinal detachment. So, management of retinal detachment. So like I mentioned before, the exam is very important in planning for surgery. We either have laser demarcation, pneumatic, scleral buckle with or without vitrectomy. Chronic and asymptomatic detachments can be observed, and I do have several of these, especially if they're inferior detachments, you can just watch them. They're
See that
asymptomatic.
citation?
Yeah.
Let's put the whole name in.
So this was the article
It's a
where
long
your
time ago.
picture was at the end, and
Yeah.
I was like, I don't know what
Years ago.
that.
A little more hair.
Cause I feel like you look the same,
Yeah.
but then you look at a picture like. oh.
Right, yeah, you
But a
gotta.
friend of mine did that to me. She sent a picture of me and Andrew from 20
Yeah.
years ago, and I was like,
No way.
oh, okay. A little different. So anyway, this is kind of an asymptomatic detachment with pigment. No treatment was done. That's just.
In several of those that I watched, they don't necessarily have to, asymptomatic attachments, even without pigment, I'll often watch them, which is different from most people.
Yeah.
And I have had one, I had one progress recently to surgery, but I think the risk of progression is well under 10%, maybe 5%.
But I've seen progression in patients that I've lasered years ago.
Right, yeah, so people.
So they can progress either way, so. Anyway. So this is, speaking of laser, so this was a patient, I think he was asymptomatic, but because he was superior, I ended up lasering. I think he's a lawyer as well. But anyway, I don't, yeah, if they're not symptomatic, I don't tend to put them through a cryopneumatic for this, so I just lasered it. And he's doing fine. He's been fine so far, but you do have to watch him because they can progress, especially if they're superior, they can start to break through that. And a lot of times, if it's just a little bit, I'll just add some laser and just kind of watch it. So. This was one that I actually did a vitrectomy on, and I do a lot of pneumatics, probably more than,
Yeah, we probably, you and I think it's age related.
yeah, maybe, yeah.
Yeah.
It's just such a time, it's just so time efficient, I feel like.
Well, the recent studies, the vision's favorable.
Yeah.
You know, if you look at
can,
the visions are better on pneumatic.
Yeah.
Less metamorphosis, yeah.
Yeah,
yeah, yeah, yeah,
Drainage.
yeah, it's kind of gentle.
I love the procedure. I mean, you do have to you have to really do a good exam, because if you miss a break, and it just doesn't work. But anyway, but this is a patient I did a vitrectomy, probably because their chairs were like all over the place, and you can see by the cryo. that I
Does your
did.
retina service do pneumatic retinopexy or no?
I started like a month and a half ago, so I haven't done any, but
Uh-huh,
I know we have the gas and the cryo, so you're able to.
Yeah.
good. Well, welcome.
Thank
This is
I
Dr.
feel like-
Agee's, Julie, now there's
Yes,
two.
I
doctors.
figured that out as soon as she said it, I just started.
Oh, you are.
Yeah.
New staff, brand new staff, we emailed.
Yeah.
Thank you for coming to conference. Yeah.
Yeah, two things I find important with pneumatics is the exam and finding all the breaks, and impressing upon the patient how important it is to position. You have to tell them, you cannot be up walking around, you can't walk your dog, you can't be making large meals. I want you sitting or whatever position, watching TV, that's it. I even tell them not to read or be on their computer or their phone. I just say, watch TV, that's it, that's all you can do. So you really have to just kind of overstate that, or they don't think it's gonna be very important a position. And I tell them, you're gonna go to surgery if this doesn't work, so.
I tell the guys, Sandy Grizzard, who used to practice here, he's probably the most famous Tampa Bay retina specialist. He died a couple years ago. But he was one of the two authors on the initial pneumatic paper, him and Hill. And he did a study afterwards on failures, a big study, and he found that it failed more often than men. So what he used to tell is men don't listen when you tell them what to do, which I think was true of Sandy. I don't think it's true of all men. And, but I tell people that, I said, so I tell the guys, like, you gotta listen, you gotta do what you're told. I tell the women too.
Yeah, but
That
it
was
helps when they
Susan's
have the
favorite.
wife there.
Yeah.
And if the wife is a nurse, you're golden.
I love when David had a patient, his wife would text him pictures of the patient.
Not the
Not
guy.
positioning.
Oh, really?
He's like, this is my husband, not this.
That was really funny.
It's really funny, the picture.
The guy had bilateral detachments. He actually done great. He's nearly 20/20 in both eyes.
Yeah.
That
With
was-
multiple procedures.
Multiple
right?
procedures,
Yeah, 'cause
including
he
oil
wasn't
in one eye,
behaving.
yeah.
Wow,
Yeah, because he wouldn't behave.
wow.
He was the
Because he wouldn't
CEO of
behave.
some big company.
He was correct. He was, it's an eye care company. And he had his in-house optometrist miss his detachment, which is how he wound up with me.
Right, yeah, interesting, but I love the picture, that's so funny.
So I got a picture of a patient who showed me how he was positioning, and he looked like he was hanging himself. It was terrible. He had like a neck thing on, and he had this like, I don't know. Anyway. So anyway, this was a
That was
vitrectomy.
a
You can
suicide
see
note.
the little gas bubble there. The gas is almost going away, so the patient is happy. Patients don't like their gas. But I remember you saying years ago, the gas bubble is your friend.
Yeah.
I still tell them.
Almost literally, people
Gas
complain
bubble
and
is your
complain.
friend.
I have artists bring in drawings with their.
Yes,
bubble
with the
and
bubble.
I tell them bubbles are like babies. I've never seen one stay in there forever.
light.
They like that. It's kind of cute, you know,
It's-
they always come out. They always go away. Don't worry.
And then this is a picture of a patient with a buckle. So, and sometimes you'll get a referral from an optometrist and they'll say, this patient has a retinal detachment. And you look and like, no, it's a buckle. And you can just tell there's an indentation. This is a 360 buckle. Anyway, this was actually a patient, she was like 16, I believe. She was in high school. And typically I'll do a buckle on young patients without a PVD. With a clear lens, you just don't want to go in the eye. So I did primary buckle. She actually had a buckle in both eyes. She had a bilateral
That's a
detachment.
beautiful cake.
Thank
Yeah.
you.
Really nice bubble.
Thank you. I like my buckles. I don't like doing buckles,
Oh,
but I like them after the fact.
Yeah. And on young patients, it's like, it's bad not to do them on
Yeah.
young patients.
Yeah, you have
Young
to do them on
patients,
young
it's such a
patients.
good procedure.
I have a
One-
story. My first buckle with Dr. Paven, I swore I was never gonna do retina that night.
And the thing is, you only do one a year, you probably like one or two.
I'm
Even
still
with this-
here, you know.
I know.
Listen,
Oh, good. No,
the residents may want to know the reason to favor a buckle in a young patient over vitrectomy is vitrectomy causes cataract.
Yeah, totally.
Invariably,
And in
invariably.
the absence of a PVD, it won't necessarily even work.
Yeah,
That's the
It's
thing.
just
So
a
young
nightmare
people
to
don't always
try.
have it. It's weird you can get a detachment without a PVD, but if you see, I've done 2 or 3 college kids, a couple med
Mhm.
students in the last couple of years with no PVD and a pretty big detachment.
yeah, yeah,
And creating a PVD is just. a disaster.
yeah. So buckles are great. So PBR, I guess I've got to go quicker. So most common cause of retinal detachment failure, about 10%. This has been my nemesis for years. I hate PVR. So basically it's from the RP and glial cells forming pre-retinal membranes. Typically, sometimes you'll see subretinal membranes that will redetach the retina. There's classifications for PVR. A is just pigment in the vitreous. B is more stiffening of the retina. And then C is actual membranes, and then anterior, posterior, and then you can measure them in clock hours. Typically, the standard of care has been surgical. There's been a trial looking at methotrexate. I love this because I hate PVR. And so at one time I had like 5 patients undergoing methotrexate just because they were at risk for PVR and one of them had PVR. So it's a great procedure. It's just an intravitreal injection that you do weekly for 8 weeks, or I do, and then every 2 weeks for next month. And my very small percentage of patients that I've done it so far, I haven't had any recurrence. They've been doing great. And I think it also decreases the risk of a macular pucker because it's just really annoying when you fix a retina and it looks great and they come in with this horrible pucker and their vision is bad anyway, so.
But it's interesting, Aldera had the license for ophthalmic methotrexate for PVR, but this study, the GUARD trial, had a problem with the statistics, so they cannot register
Okay,
methotrexate for PVR. They're keeping the license for intraocular lymphoma. They've
Okay.
returned the license for methotrexate to Dean Elliott, who developed this and was running the GUARD trial and had the licensing deal with Aldera. So he's going back to the well. I just connected him this week with my buddies at Harrow to try to do another trial and re-register the drug. But the upshot of all that is we're still going to be able to get cheap compounded
Yes,
methotrexate for
right.
at least many more years for this.
yeah, you just
Instead of-
use it off
instead of
label.
Whatever Aldera is whatever they were gonna charge for, which was gonna
Yeah, I'm
be
sure.
incredible.
And you use a lot of it.
Use a lot of it, yeah,
You
use
use
it
a lot of it. so.
Weekly for 8 and
It's a
then,
kind of a pain to draw it all up, but I just draw it up. It's kind of fun to see how many syringes you can get out of
We
one
get it in
vial.
we get it compounded, yeah.
I've gotten them in vials and I've
Okay.
drawn them up
All right.
myself. I haven't done it in a couple months.
Okay,
but-
we have this, if
Oh,
you want,
yeah?
they can order
Time
syringes.
will,
Oh,
time
okay.
will, lighters will send it to you.
Okay, that's good to know. But anyway, that's that. This is a picture of a patient with PBR. This is a guy who did a buccal vid. He actually had a macular hole, chronic macular hole that I fixed at the same time. And, you know, he's got a lot of atrophy there because it was just a chronic hole. So his vision didn't really come back, although his hole was closed. And then he started to develop some peripheral PBR. I'm actually watching this. It hasn't progressed and his vision's not great anyway, and he doesn't want any more surgery. So I'm like, that's all good. So this is a tractional detachment. Typically, the most common thing you'll see with diabetics, sometimes sickle cell. They look a little different. They look more concave. You'll see these pre-retinal membranes. This was a patient who went and had anti-VEGF therapy with another doctor who never followed up again, and then she detached. And so basically, the only treatment for this is surgery. It's actually doing pretty well.
Is she?
Yeah.
That's what
She
Yeah,
looks,
yeah.
yeah, so
That's
I put oil in. She did redetach under oil and I was like, oh, this is gonna be a big surgery. So I took her to surgery and literally it was one little vitreous strand that pulled up on the retina and I just trimmed it and her retina flattened and she's doing great. I'm gonna remove her oil next month. So, yeah, she's a young, pretty young, very nice. And she said, so the other thing I'll tell you, when you see these patients and they're like, well, I don't have any problems with the other eye. Look at the other eye. She never had treatment in her other eye and she was 20/20. And you'll see all these new vessels that are very subtle, but you look, and you're like, and she never had treatment or anything. Nobody recommended treatment for her fellow eye. So I've been treating her fellow eye as well, just to retain her vision. So exudative retinal detachment, diagnosis is important because it does have a bearing on how you treat, because you don't really treat the detachment, you treat the underlying cause. And it's caused by leakage from either retinal blood vessels or disruption of LPE or a lesion causing leakage. Shifting fluid is one thing you can use to help diagnose that. So you'll see the patient with the subretinal fluid inferior, and you lean them back, and then the fluid will shift to the posterior pole. And you can actually see that on D-scan, different positions. The surface of the retinal detachment is smooth. You don't see those fixed folds like you would in the rhegmatogenous retinal detachment. And then causes tumors, inflammatory diseases, central serous, probably most common, and coats, and treatment is typically non-surgical as far as retina. So this is a patient, she was like 35 with metastatic breast cancer. Kind of sad, but she had decreased vision because she had this lesion and then she had a bunch of subretinal fluid. So eventually, I mean, she was on systemic chemotherapy and then she ended up getting radiation, which helped regress the masses, and then her retinal detachment fixed on its own. And then I just added this slide. I wasn't really gonna, this is just kind of the end of your chapter. I was gonna leave out the slide, but I'm like, okay, I just add it. So optic nerve pits and macular holes. So basically optic nerve pits, I don't see these too often. They're small defects in the optic disc, usually congenital. I guess glaucoma can cause them. I've never seen that. They can lead to serous macular detachments, and either the subretinal fluid they think comes either from the CSF or the vitreous. You've treated these.
We had, yeah, David and I.
Yeah,
did a
you
good-
guys
we had- There's a
had
very
these.
good procedure. If you ever have an exudative detachment.
It was like we did it,
Yeah.
it was with my
So what'd you do? You did a
Fence
vitrectomy?
structure.
greatest moment at all children's, what used to be the all
Back to
children's
back.
retina operating
Yeah.
room.
So we did what's called a retinal fenestration,
Yeah. Okay.
which is like perfect.
Yeah.
Okay.
It's a
So you
nothing
just do a
surgery.
You do a little-
PVD and
you-
then
Nothing.
just
MPR
scrape
blade.
the.
Just you go parallel nerve fiber between the nerve and the macula with the 25 gauge needle. You just go like 5 or 10 scrapes so you can see the retina, not making a hole in it. And that's it. Takes about 10 minutes and they both
Pretty
flatten
easy.
over about 6
All
months.
right, well.
And we
I'll tell you if I
observed
get
both
one.
of them for 6 or 12
Yeah.
months, so they were
And they were
real.
fine.
We did them back to
That's
back.
cool.
Yeah.
Did we create a PVD? I don't think we
No.
did. I think we
Oh, you
did.
didn't
one.
even create a PVD?
No.
I
Oh,
think we just went in.
You just
tickled
go
it.
in,
Yeah.
you make a little cut just to make a path for your needle, you scratch it, and then you come out. Yeah, Rick Spade, I think, came out with it.
the procedure?
Where did you scratch it? Yeah, you right, we did it just temporal to the optic nerve where the pit, we're right where the pit was, you know. and the
Yeah,
fluid's
parallel to
coming
the
out,
fiber layer,
you know,
so you're not
within,
killing
like,
the
in the
vision.
radiations and the.
Yeah.
And you're not making a hole, you just kind of touch it, you can see the retina move,
Yeah.
and then you just stop. And then and then what happened, the presumption is the fluid then can
Comes
exit,
through
you're
the-
disrupting the internally membrane, so the fluid can exit the retina into the vitreous and then the retina.
No
In both
gas.
of the cases, or
Yeah.
And
there's a
then-
paper in the literature, I think with 12 patients, and the
Yeah.
success rate was 10 or 11 out of 12.
That was the paper that we, and it is not something that I've done.
And
since
no
then.
gas or anything.
It's rare, they
No
usually
gas
go
or
away,
anything.
they usually,
Right, no
the
gas.
fits, they usually get better, you watch them, they get better, so, or you, and I think we might have tried laser, but honestly, laser usually.
I don't think I've tried laser on those.
Yeah.
I don't think
right
laser
on
does, it
laser.
doesn't make sense, it doesn't. do
No, it
anything.
doesn't make sense to me. I just,
A lot of optic nerve pits closed. One of you guys presented one of mine. I had an elderly patient with a nerve pit and it just closed. You know,
What
I just
about
watched it.
doing like island view?
Well, that's what in a 10-year-old, it's,
Yeah.
Yeah, it's hard to see
Yeah.
that.
yeah, that's gonna be a real bear.
and then macular holes don't typically predispose to retinal detachment, so you kind of have that conversation with the patient, but if they're a high myope, sometimes they do, if they have a posterior staphylloma. And then, you know, the vitreous fluid can dissect through the hole and create a detachment. And they're a bit more difficult to treat than typical retinal detachments or macular holes. Any questions?
That's it. Questions about everything? That was a lot. Thank you. That was
Thank you, that's
excellent.
great. Let's do a quick intro. So
Yeah.
you're brand new. I'm David Eichenbaum. I trained here. I finished at the University of South Florida Department of Ophthalmology in 2005.